Good morning, ladies and gentlemen. Thank you very much for the invitation to this magnificent event. My case comes from the Lviv National Medical University, Departments of Urology and Radiology, and Medical Center Euroclinic, Lviv, Ukraine. This case is dedicated to the pitfalls of the multiparametric MRI in differentiation of the prostatic lesions. The clinical history of the patient, which occurred during the corona era, the patient 63 years old with diabetes mellitus, which is moderately controlled, in April 2021 was hospitalized to a regional hospital with a high temperature, pronounced chill, general weakness, increased blood pressure with no pain, with a insignificantly increased CRP, normal D-dimer, and negative SARS-CoV immunoglobulin test. The source of infection was not defined, and the patient was treated with antibiotics, and after the improvement was dismissed. However, 5 months later, in October, the patient was again hospitalized to regional hospital due to the acute urinary retention. The patient was catheterized. The patient had a high fever, frequent chills, which were more pronounced than during previous hospitalization, general weakness, headaches, increased blood pressure during the last 2 weeks. Again, with no pain, with a high leukocytes, significantly increased CRP, ECR, and blood sugar. Also, the PCA was increased, and the ratio of the PCA was 4.96. According to the USG data, there was incomplete kidney duplication, right renal cyst, features of the chronic pyelonephritis, and BPH. According to the chest and abdominal CT, no pathology was found. According to the echocardiogram, the ejection fraction was 47. The patient was consulted by the urologist, and the BPH was diagnosed. So, in result, the diagnosis was arterial hypertension of second stage, coronary heart disease, heart insufficiency, hyperthermia, and of not defined genesis. The patient was treated with the antibiotic of cifepime 1 gram 1 per day and dexamethasone, and was dismissed with the improvement of the symptoms in the beginning of the December of the same year, with the leukocytes 6.5, CRP less than 6, still increased ECR 2024, normal urine analysis, increased blood glucose, and urinary catheter was removed, and patient urinated by himself. And patient was recommended to take the methylprednisolone and consultation of the infectionist and rheumatologist. However, few weeks later, after the discharge in December, the patient was again consulted by urologist due to the moderate pain in the pelvic area, mostly perineal, over the urinary bladder, and patient took methylprednisolone for the last 2 weeks, which is important to know. Also, patient had a severe dysuria, PSS was 30, periodic high fever, severe chills, general weakness, headaches during the last 10 days. Rectum prostate was moderately increased in size, moderately painful, no feature of cancer, and in the multiparametric of the prostate was recommended, and at this point the patient got to our clinic. The patient was hospitalized in December of the same year with a high leukocytes, very significantly increased CRP, very high ECR, blood glucose, urine analysis was normal, and increased PCA. And the multiparametric MRI was performed. In result, in the right lobe of the prostate with the periprostatic involvement, there was a lesion, hyper intensity signal on the T2 weighted images, which had a thick septa, and resulted in the restriction of the diffusion of DVI images, which was very significant. We can see it on the T2 DVI fusion maps, and very significantly decreasement of the apparent diffusion coefficient, which is very characteristic to the clinically significant prostate cancer. And according to the dynamic contrast enhancement images, the prostate tissue significantly accumulated contrast with no center presence of the contrast enhancement, so-called ring pattern. So my first question is, what is the pyrite score of this lesion? And the second question is, what is diagnosis? And sure, the diagnosis should sound like a multiloculated prostate abscess, And according to literature data, there is a problem with the scoring of such kind of lesion, hyperintense on T2 weighted images with the restricted diffusion, when they located in the peripheral zone. In this case, this lesion could be scored as the PIRAT 3, 4, or even 5, and only together with the clinical history we can be oriented toward the diagnosis of the abscess. However, in our case, the lesion was located mainly in the transition zone, and the key of the correct scoring of this lesion, and this lesion was scored as PIRATS 1, was that when we got a transition zone lesion and it's hyperintense regardless of the diffusion, this restriction, this lesion should be scored as the PIRATS 1. And on this second image, we can see an example from our clinic with the hypointense features on the T2 weighted images, which are very characteristic for the prostate cancer in transition zone, which was scored PIRATS 5. And of course, ring enhancement pattern with no enhancement in the central zone of the lesion, also highly suggestive not on the prostate cancer, but for the abscess. In our patient, methylprednisolone was immediately cancelled. Blood culturing was blood samples were taken for culturing. Immediate antibiotic therapy was launched. It was levofloxacin in combination with the metronidazole, and a patient consulted by endocrinologist in order to control the blood sugar. Treatment with a transrectal ultrasound guided transrectal needle biopsy, leverage with the saline and antibiotic levofloxacin and metronidazole was performed, and in result approximately 60-70 milliliter of pus was evacuated and sent for the culturing. In order to facilitate this process, we performed maps from the diffusion weighted images, taking into consideration very significant restriction, using the maximal intensity projection, and also it was very useful to use three-dimensional reconstruction based on this sequence in order to facilitate this evacuation process. In the result of pus culturing, Escherichia coli was found sensitive to the levofloxacin. Blood culturing, no culture, antibiotics were continued, and patient symptoms improved. On the 7 days, USG was repeated, and only a paraprostatic lesion, which earlier we can saw on the multiparametric MRI images, was found. We performed evacuation of this lesion using the previous approach, and in result we received no pus but only exudate, which was also sent for the culturing. The antibiotic therapy continued, and on the 14th day the symptoms of the patient significantly improved. Leukocytes, CRP fell down, urine analysis was normal, IPSS significantly improved from the 30 to 7, and also PCA level was normal. Patient was dismissed and continued oral levofloxacin for the next 7 days, and on month there were no features of the abscess on the USG, as you can see on this image, and blood analysis was normal. So to conclude, many conditions may yield abnormal signals within the prostate, including the abscess, hemorrhage, cyst, calcification, atrophy, and fibrosis are benign and highly recognizable on MRI. But in our case, we saw that CT and USG were of limited value. However, there are no guidelines to how to score the prostate abscess according to PIRATS system, along with the ring enhancement DCA and restriction of diffusion. Such lesion could be mistakenly scored as PIRATS 4 or 5, especially if they are located in the peripheral zone. So we must take into consideration also the history of the patient. Patient with the diabetes mellitus require meticulous approach, since the treating diseases of the prostate like abscess in the first stage tend to be asymptomatic, like in our case, and can be masked by other diseases. Thank you very much for the attention, and thank to the European Association of Urology for the support of Ukraine in these dark times.
Дуже дякуємо. Просимо наших експертів прокоментувати це дослідження і можливості різних помилок або складних ситуацій в діагностиці ураження передміхорової залози. Особливо тут такий варіант, коли великий абсцес, і в принципі за допомогою МРТ його було легко диференціювати, да? Але бувають іноді дрібні абсцеси, особливо у пацієнтів з діабетом, супутньої патології, які можна фактично не діагностувати за допомогою КТ і важко класифікувати за допомогою МРТ. От якраз то питання, як мають класифікуватись такі пацієнти по класифікації ПРАЦ, 3, 4 або 5. Відповідно, якщо правильно не буде встановлений діагноз, буде виконана відповідна пункція, яка, напевно, для якихось пацієнтів буде не потрібна. От такі питання експертам, як ви відноситесь до МРТ-діагностики, до чутливості, специфічності в таких саме випадках? Дякую.
Так, дуже дякую за цей клінічний випадок. Я повністю погоджуюсь, що насправді є певні обмеження стосовно шкали Пірац. Безперечно, це певне виключення. Зазвичай ми використовуємо МРТ для раннього виявлення раку простати, зазвичай у асимптоматичних пацієнтів. А після цього дійсно ми можемо використовувати шкалу Пірац для того, щоб прийняти рішення стосовно наступних кроків. Проте це цікавий випадок. Дійсно важливо, щоб радіологи використовували не тільки шкалу Пірац, проте надавали також і опис самого враження. І таким чином ви зможете надалі зрозуміти, які ще потрібні додаткові методи дослідження для того, щоб краще специфікувати патологію. У мене є одне питання, до речі. А діагноз був правильний, згоден з цим, це був абсцес, це була інфекція. І після цього ви вирішили зробити аспірацію за допомогою трансректального підходу. Чи думали ви про те, що використовувати транспіанальний підхід, транспереніальний?
В клініці Львівської клініки у Львові, це регіональний центр урологічний, перініальний підхід не застосовується, тобто не на потоці методика трансперініального підходу взагалі. Тобто всі маніпуляції такі виконуються трансректально.
Так, зрозумів. Що ж, знову ж таки, коли ми говоримо про ПЕТ-КТ, безперечно, нам потрібно робити те, що ми можемо. Так само, як в випадку з ПЕТ-КТ. Проте варто подумати, що, можливо, в майбутньому, коли все стане більш доступно, що варто робити саме такий підхід, трансперініальний підхід. Чому? Тому що є висока ймовірність вторинного інфікування. І через це, коли ви будете використовувати аспірацію трансректально, ви також можете, можливо, зробити фістулу. Крім цього, чудовий клінічний випадок. І мені здається, що чудова терапія, чудова діагностика. І також клінічна відповідь на терапію також була чудовою.
Ваші коментарі і вашу думку.